This is a presentation that I've prepared for senior residency training and for junior faculty who are specializing in neuroradiology. So I work in a neuroscience institute and we specialize in all neuro all the time. So we have CT and MR. We spend a lot of our time with difficult cases on MRI. CT is extremely useful for cerebrovascular diseases because CT angiograms, CT perfusion are very sensitive and excellent for quick assessment of many diseases. But for MRI, the range of findings is very limited, and we spend a lot of our differential diagnosis on MR. So my presentation is going to be quite MR heavy, and it will be based on an article that you can download freely. So your organizer has very kindly shared in the chat the link, the web link on the internet. So if you have internet right now, you can click on that link and hopefully it will take you to the Springer publisher website. You should be able to see the article. And at this point, I will stop sharing and I will share the website. And this is what I'm talking about. The IDKD course has an edition of a PDF book. And with this website, you can download the PDF. It is free to do. And I wrote this chapter, and I will be using the PowerPoint today to share the basics. So before we go, I have a few disclosures that are not relevant to this presentation. They're mostly research grants and artificial intelligence industry collaborations. I'm also a board member of the International Society for Magnetic Resonance in Medicine. So in terms of infections, I'd like to start with two cases. This is case number A. It's a 30-year-old man with fever, seizures, and leukocytosis. What is the most appropriate diagnosis? Is it number 1, Wilson disease, 2, malaria, 3, herpes, and 4, metastasis? So let's have some time to think about that. We'll do the reveal as we get closer to the relevant topic that I will be presenting. And this is question B. It's a 29-year-old woman who has features of involuntary twitching of the limbs and grinding of the jaw. Is the diagnosis 1, meningococcal meningitis, 2, tuberculous meningitis, 3, metastasis, or 4, none of the above? So here we have a patient with post-contrast MRI, and there are some features that you can see which are a little bit unusual. So here we have a few responses in the chat. So that's quite good. Let's move on to the scope of what I hope to share with you in about 40 minutes or so, because I don't think that our attention spans are meant for anything longer than 45 minutes. I shall attempt to be brief. The section chapter in the PDF book, I will start with focusing on the approach and techniques, which is sections 6.1 and 2. And then the meat, the key portion of the presentation will be on patterns and the recognition of these patterns specifically on MRI. We will talk about the typical patterns of meningitis, abscesses, and parasites, and take a short detour on HIV and some of the specific abnormalities that we can expect, including toxoplasmosis, tuberculosis, and a phenomenon called iris. Then we'll move to the viruses, because in addition to the bacterial processes of meningitis and abscess, and the parasites, and the tuberculous organisms, we need to include the viruses, which have a slightly different pattern from bacterial infection. Now, the rest of the chapter will be on inflammatory encephalitis, which is a very rare condition, and it is still being sorted out in the literature. So I shall cover this very briefly. We'll take a short break at this point between 6.7 and 6.8, and we'll see where we are. And finally, a few words on how radiologists can help in the clinical assessment of patients who have CNS infection. Okay, so let's start with sections 6.1 and 2, the approach and the techniques that we can use. Infections compared to other CNS conditions is quite rare. We typically, in our case mix, see many patients who have trauma. That includes high velocity, motor vehicle accidents, what we call RTAs, road traffic accidents. We also have fall from heights, assault, and minor trauma, which is becoming more and more common, especially in our aging population, where old people fall down and we don't know if the patient has had a brain trauma or head trauma or head injury, but patients come for routine CT studies very commonly. Cerebrovascular infections and trauma are very much more common than infection or tumor. However, tumor has very good research, and much resource and funding has gone into research in tumors. So now we know about the WHO molecular classification of glioblastomas. But comparatively, there's very poor research data on CNS infections. It lacks high quality radiology literature and facts about sensitivity, specificity, and accuracy of some of the features that I am going to describe. So that's one of the inherent drawbacks, unfortunately. Randomized controlled trials are very, very few. However, I have had the good luck or the bad luck of being involved in outbreak CNS imaging, such as SARS, Nipah virus, and of course, COVID. During COVID, CNS imaging in COVID patients contributes somewhat, but it very often ends up confusing many radiologists. So in this background, we understand that infection seldom comes to MR scanning, but when it does, we should be prepared to distinguish the approach to radiological features. The classification of CNS infections is very wide. There are many, many different classifications. Textbooks are written from the pathogen approach of bacterial infection, virus infection, fungi, and so on. They also divide into anatomical. Don't forget the brain and the spine, the head and neck, the base of skull, the ear, nose, and throat. These can all be infected. And some crossing of categorizations which are difficult. So for instance, pediatric infection is a very difficult topic. HIV cuts across multiple pathogens, and TB can affect multiple anatomical systems simultaneously. What I will be presenting will be a simplified pattern recognition of some different organisms. And sometimes you will also realize that there is common pathogenesis that MRI is very helpful in distinguishing. For instance, bleeding, microhemorrhages, and restriction in diffusion in pus, wherever pus may be found. The specific diagnosis of the organism is very, very difficult because there's lots of overlapping patterns, and nearly every virus can give rise to microhemorrhage, and non-infection, just the fact that the patient is admitted to the intensive care unit and is in a coma can give rise to some common pathogenesis and brain damage, irrespective of the virus infection. And the virus doesn't even have to attack the brain, such as in COVID-19. It's very difficult for us to obtain pathological confirmation of many of the infections. We try to do everything short of a brain biopsy or an invasive operation. We will use the CSF, the peripheral blood count, PCR, serology, immunochemistry, and MRI as much as possible without necessitating neurosurgical intervention. And of course, identifying the pathogen, we can guess that something is TB, but we will not have confirmation. And for many bacteria, it's important to isolate the organism, identify it, and then look for antibiotic sensitivity, especially in multi-drug resistant pathogens. So we will anchor the pattern recognition on 3 typical patterns, starting with meningitis, followed by ring-enhancing abscesses, and finally, virus encephalitis. We will blend some of the pathogen classifications, and we'll look mostly at bacteria and parasites before moving on to viruses. And I want to emphasize the importance of the multidisciplinary team where neurology, neurosurgery, infectious diseases, radiology, and sometimes even public health, we bring our own specific expertise. So as a radiologist, we must bring our A game and be aware how these individuals approach the diagnosis, while we add how we can pattern recognize and bring value to our approach. Now, with regards to the techniques that we can use for MRI, for CT, it's relatively straightforward. We have the option of unenhanced CT, enhanced CT, and sometimes CT angiogram and CT venogram. These can all, of course, be replicated in MRI. We can use conventional MRI. We typically have a T1 weighted pre-contrast to compare with the post-contrast MRI. The contrast-enhanced MRI will need the T1 for comparison because high signal on T1 caused by methemoglobin in blood, protein, and other causes should not be mistaken for an area of enhancement, which is quite important in infection. So a T1 pre-contrast and post-contrast enhancement, a T2 weighted imaging, and flare. We will need the high sensitivity and high specificity of flare, particularly in assessment of the hippocampus, as I shall show you in virus encephalitis. We typically have high-resolution, thin-section, contrast-enhanced MR after injection of gadolinium, don't forget on T2, we can also get 3D thin section imaging using steady state imaging or Fiesta. I've highlighted diffusion weighted imaging because I have found it to be very useful in assessing abscesses and meningitis. Gradient recall echo, and more recently, susceptibility weighted imaging have been very helpful for detecting microhemorrhages and calcium. Although calcium is very, very well described in CT, microhemorrhages are not. Macro, large hematomas can be very easily seen with CT, but small, tiny microhemorrhages are very much better detected using SWI. Of course, MRA and MRV with a variety of methodologies, time of flight, phase contrast, and lastly, contrast-enhanced MR angiogram and MR venogram can be acquired as part of the study. And CT can also give you angiogram and venogram. These are what I would consider conventional imaging. In other words, these are things that we use and see daily in our practice. There are some special pulse sequences that we can use. For instance, DTI using diffusion principles, and not important for diffusion kurtosis imaging. But DTI isn't as helpful, so I won't be speaking too much about it. Perfusion imaging, either using dynamic susceptibility contrast enhanced perfusion or arterial spin labeling, ASL, can be helpful in distinguishing a ring-enhancing lesion caused by an abscess from a ring-enhancing lesion caused by a necrotic tumor. So perfusion imaging studies the relative cerebral blood volume and blood flow of the lesion. So here is an example of a dynamic susceptibility contrast enhanced study showing an area of the ring enhancing lesion as low perfusion. So this low perfusion gives us a bit of confidence that this is less likely to be a GBM and more likely to represent an infective cause, such as an abscess. MR spectroscopy sometimes can be helpful as a tiebreaker because on MR spectroscopy, in abscesses, the choline isn't elevated, but instead there is a large peak of lipid lactate. I want to say a few words about contrast-enhanced MR. You can get contrast-enhanced T1 weighted imaging. You can get contrast-enhanced FLAIR imaging. And finally, you can get contrast-enhanced black blood, black CSF, vessel wall imaging. So this pulse sequence is very useful, and I think it's called SPACE in Siemens, and in GE and Philips, it's called black blood, black CSF. Now I'll show you some examples of this in the next slide. So here is an example, figure 6.3 in the PDF text of post-contrast enhanced leptomeningeal contrast enhancement, as well as post-contrast flare in the same patient. So abnormal blood-brain barrier breakdown and leakage of contrast into the leptomeninges and the meningeal space, as you can detect here, as abnormal high signal intensity on the contrast-enhanced flare. So there are many ways to look for abnormal contrast enhancement in meningeal disease and meningitis. So let's get first into the bacterial infections where we're going to look for meningitis, an abscess, empyema, the pattern recognition of meningitis. So the classic in MRI, as well as to a certain extent CT, is that we're looking for abnormal leptomeningeal contrast enhancement. Here you can see focal area of enhancement outlining the gyral surface and the dural surface with the abnormal CSF tract in between. So after contrast injection, we can see abnormal enhancement. And in this particular patient, and in all patients, the area underneath, the area of brain underneath the meninges is very susceptible to infection, cerebritis, and subsequently abscess. So this patient had leptomeningitis here and parenchymal infection. This is cerebritis, and if given enough time, uncontrolled infection will start to build abscesses here. These are two different patients, but this is an example of a patient with small amount of meningitis and pus in the subarachnoid space. Previously, we had seen that there's abnormal ISO signal in the CSF space here. The CSF is murky, full of proteinaceous material, different than the healthy CSF, and this can be detected as high signal intensity on flare in the subarachnoid space diving into the sulci. Flare can be quite sensitive, but on diffusion-weighted MR image, it's even more sensitive than flare. Here you can see small pockets of restricted diffusion in the subarachnoid spaces of this patient who has meningitis. This is the same patient as this patient. So the DWI has excellent abnormal to normal contrast. Now, this is a different patient, and everything else was completely normal. There was no abnormal contrast enhancement on post-injection T1 weighted. There was no flare, high signal intensity in any of the subarachnoid spaces, but we were able to detect an area of high signal on DWI within the dependent portion of the occipital horn in the lateral ventricle. This is also a small collection of pus. Okay, apologize for the red lines appearing. So we didn't switch off the drawing function. Let's move on to the distinguishing feature of meningeal enhancement. Previously, I had explained leptomeningeal enhancement, and this is a patient with abnormal leptomeningeal contrast enhancement. This is a patient who has enhancement of the dura mater. This is enhancement of the arachnoid mater, as well as hydrocephalus. So these two patterns of enhancement are very different. This is typically exudative contrast enhancement plus hydrocephalus. We should suspect tuberculosis, as well as look at the 8th cranial nerve for abnormal cranial nerve contrast enhancement. These are all the clues that will give us a diagnosis of leptomeningeal enhancement and leptomeningitis. In contrast, pachymeningeal enhancement is like a thick felt tip pen that outlines the outside, the fibrous dura that surrounds the outside of the brain. It's different than the leptomeningeal contrast enhancement. And the differential diagnosis of both of these is also different. So for instance, for leptomeningeal contrast enhancement, they can be caused by chemical meningitis, cancer, which is typically nodular, and it may be metastatic or lymphoma. Very, very rarely you can get carcinomatous meningitis from primary CNS tumors. It's typically glioblastoma. Subarachnoid hemorrhage can also sometimes give you contrast enhancement, as well as drugs and ischemia. The differential diagnosis for pachymeningeal enhancement of this pattern is also very different. Although they can be caused by granulomatous disease, typically TB, focal or diffuse dural enhancement is more often seen in non-infectious inflammatory conditions such as sarcoidosis or IgG4 or meningiomas, and in this patient with very diffuse bilateral dural enhancement, the cause was intracranial hypotension, what was called SIH. So, from leptomeningitis, we move on to the ring-enhancing lesion, and the next pattern recognition is abscess. So these are two different patients with abnormal rim enhancement, high signal intensity on T2, and one of them has metastasis from a lung primary. The other patient has a cerebral abscess. Very often, the patient will present with fever if they have an abscess, but sometimes in a patient who's immunocompromised, even something simple as diabetes, you may not get fever or leukocytosis in a patient with cerebral abscess. So how can we tell the tumor patient from abscess using MRI pulse sequence? And here we can see that the diffusion-weighted MR imaging is different in the two different conditions. In a patient with an untreated abscess, the restriction of diffusion usually has high DWI signal and low ADC, whereas the classic metastasis typically has low signal on DWI. There are some exceptions to this rule, and it's important to realize that untreated abscess will give you this finding if successful antibiotic treatment is started, that high signal intensity and low ADC will start to normalize. There are a few types of metastasis, including adenocarcinomas, that can give you the false positive of a high signal intensity. But by and large, if we have high signal intensity on DWI, we should suspect abscess. If it's low, most of the time, it's due to metastasis. So we have to understand that there are many differential diagnoses for ring-enhancing lesions. Yes, is there a question? Okay, if there isn't, I'll carry on. Amongst the ring-enhancing lesions, we should be aware that infection is responsible for the pyogenic abscesses, tuberculomas, and some of them can be TB abscesses. They can be fungal. They can be due to parasites like toxoplasmosis and neurocysticercosis. Ring-enhancing lesions can also be non-infectious, typically metastatic or, which can be thin-walled, and primary glioblastomas, which are usually thick-walled, or lymphoma in very unusual circumstances. Don't forget, a ring-enhancing lesion can also be caused by a subacute infarct. They can be caused by contusion and hematoma. If we have prior imaging, this helps us a great deal. And finally, the incomplete ring enhancement of a tumefactive demyelinating disease. So as I've said, at the multidisciplinary team meeting with the infectious disease and neurology and neurosurgery, the problem solving will start with getting a history of fever, examination, total whites, leukocytosis, and we can offer the differential diagnosis and perhaps introduce advanced MR techniques such as perfusion or spectroscopy if it will help to distinguish infection from non-infectious diseases. A last word about empyemas. This is a patient who has a fluid collection which enhances in a rim-like fashion and a fever. So we thought this was pus, and it was supported by restricted diffusion on diffusion weighted imaging. So an empyema behaves very similarly to an abscess because it is a collection of pus. So let's move on to the parasite causes of ring-enhancing lesions and focus specifically on cysticercosis and schistosomiasis disease. Among the parasitic diseases, we will cover toxoplasmosis later in the HIV section. So the life cycle of the pork tapeworm, which is endemic in many parts of Asia and the Americas. I'm not sure whether you see much of it in Africa. So I'd like to learn whether this is a common disease that you encounter. And the CNS manifestations cause epilepsy and seizures. So amongst the developing world, this is one of the commonest causes of epilepsy. And neurocysticercosis can be recognized because there are 4 different stages of development. The tapeworm affects the brain, and it starts off in the vesicular phase. This is a non-enhancing cyst with a scolex that represents the worm. So the cyst shows isosignal to CSF, in other words, it's extremely high signal intensity on T2 weighted MR imaging. There is no enhancement and no edema. After a while, the scolex dies and it becomes a colloidal vesicular cyst. It is no longer isosignal to CSF, and the flare will have increased signal intensity, a lot of enhancement, and a lot of edema. From there, it becomes more granular and nodular and gets smaller. The edema is less. The enhancement becomes thicker and more solid rather than the ring enhancement that we typically see here. And the cyst becomes smaller. It becomes so small that ultimately it calcifies and mineralizes and is easily detected on CT. There will be no more cyst, nor edema, nor enhancement. So these are the 4 stages of neurocysticercosis, and the diagnosis can be made quite well on a CT, which is sometimes all that is necessary for diagnosis, especially if there's endemic tapeworm. So here is the vesicular colloidal area where without contrast enhancement, you can still see that there's edema in the active colloidal phase. And here is a second lesion, which is the chronic nodular calcified phase. So detecting multiple lesions in different stages of development is the most helpful tool that we have. So there are 2 patients here. This top row is a patient who has abnormal edema, a ring-enhancing lesion, which you can see on the post-contrast study, and a second lesion and a third lesion. This one did not enhance, and therefore it is different stages of the scolex and the vesicular phase. So this gives us a good clue that it is cysticercosis. It's a different patient, again with a ring-enhancing lesion surrounding edema, and on some thin section flare studies, you can see that there's a scolex in the periphery of the rim that gives you some indication that this may be cysticercosis scolex. So let's move on into another organism, and I won't spend too much time because this is a very unusual situation. This is a patient with schistosomiasis japonicum, which is endemic in Asia. There are 3 distinct species of schistosoma with distribution in different places, and schistosoma mansoni and hematobium are detected in Africa and the Middle East, as well as South America. The characteristic, unfortunately, I don't have much experience with the other 2, but the japonicum species typically is made up of a very large mass and space-occupying lesion with edema comprising of multiple nodules and linear enhancement that makes it look like a bunch of grapes. This is important because this disease is very often imported by patients traveling from the endemic areas to the non-endemic areas. And this is very often mistaken for a tumor, and patient undergoes biopsy with a result that is not a tumor, but a parasite. So to finish off the parasites, there are 2 broad categories of parasites, and I've discussed the multicellular worms. These are metazoan parasites and comprise flatworms such as cysticercosis and schistosomiasis, and roundworms, which comprise rarer conditions that can sometimes, but very, very rarely, affect the CNS. Single-cell protozoa, including amoebiasis, malaria, and toxoplasmosis, which we will encounter in HIV. Now, as an aside, trypanosomiasis is a very unusual diagnosis to make on MRI. The challenges in health systems means that the American trypanosome disease is sometimes diagnosed, but the African sleeping sickness is very rarely described in the literature. If anybody has a case, please contact me. I'd be really interested in what the appearances are. So don't forget, parasites can be single cell, like toxo, and multicellular worms, such as the 2 conditions that I've shared. So now let's jump into HIV and opportunistic infections, specifically what I mentioned, toxoplasmosis and tuberculosis. So in acquired immunodeficiency syndrome, the complications of AIDS includes the following. The most common complication is opportunistic infection. And AIDS defining diseases are often detected in patients who have the first diagnosis. And in our population, toxoplasma, bacterial infections, and tuberculosis, particularly multi-drug resistant TB, are important for us to detect and diagnose. The differential diagnosis of an opportunistic infection is primary CNS lymphoma. These two usually present as abnormal mass lesions. There are two other conditions which I will describe a little bit later, and they include the HIV-associated neurocognitive disorder, used to be called HIV-associated dementia, and it is now called HAND. This affects the white matter, so it's important to distinguish it from progressive multifocal leukoencephalopathy, PML. Both of them can affect the white matter without the features of infection or lymphoma. And finally, I would like to say a few words later about IRIS, which is immune reconstitution inflammatory syndrome. So here's a patient with toxoplasmosis in the PDF. It's figure 6.8. On T2 weighted MR imaging, you can see multifocal areas of high signal intensity in the white matter, as well as abnormal signal intensity that may appear as peripheral enhancement. Some of these lesions, like here, and to a lesser extent here, display the asymmetric target sign. This is a very helpful feature that helps us to diagnose toxoplasmosis because the parasite is distributed in a very asymmetric manner, and there is blood-brain barrier breakdown, giving this appearance on multiple planes. Now, if it's not in the correct plane, you might just get a small ring-enhancing lesion, but if it is opportunistically imaged, sometimes we can see the asymmetric target sign. Although this is very helpful in the diagnosis of toxoplasmosis, be aware that in rare instances, the asymmetric target can also be seen in metastatic and TB lesions. So it's not 100% specific for toxoplasmosis, and it's not 100% sensitive. So from toxo, I want to move on to CNS tuberculosis. Now, from the publication in New England Journal in 2004, the diagnostic criteria for a patient who has meningitis to be considered TB meningitis, we have the possibility of definite TB meningitis if we detect acid-fast bacilli in CSF. If we don't have acid-fast bacilli in CSF, probable TB is important for us to suspect if one of the following or more are present. So patients who have active pulmonary tuberculosis on the chest X-ray, acid-fast bacilli on any specimen other than CSF, because that would give you definite, will be probable. And of course, if there is highly suspicious TB of the urinary tract or the gut, that is also very helpful that the meningitis we're dealing with is probable TB. If we don't have any of those, possible TB would have to have at least 4 of the following. So these are all features that make us suspect that the meningitis is caused by TB. First, the history of pulmonary TB in the chest. If there's a duration of illness in a subacute range, not the acute bacterial meningitis, but a subacute onset, and altered consciousness and focal neurological signs. If we have CSF, and the CSF is yellow instead of clear, has lymphocyte predominance, and has a ratio of glucose in the CSF to plasma that is very low, then we should suspect TB meningitis as a cause of the leptomeningeal contrast enhancement. So that's the clinical TB diagnostic criteria. For the MRI TB features that we see, we typically see them in a patient with 5 or 6 days of subacute onset of meningism and infection features. The sine qua non for TB meningitis is a thick exudative contrast enhancement, particularly in the basal cisterns of the CNS, such as here. So you see thick enhancement outlining the basal cisterns and the Sylvian fissure, as well as hydrocephalus. We should look for contrast enhancement of the cranial nerves, as well as other parts of the meninges, such as thick exudative meningitis in the vertex. Apart from hydrocephalus, the other complications of TB meningitis include infarction and vasculitis. If we see contrast enhancement of the arteries, the vessel walls on vessel imaging, that is important for diagnosis. Not only do we get meningitis, we can also detect enhancing tuberculomas and sometimes tuberculous abscesses. Of course, we got to make sure we look outside the brain for TB in chest X-rays. For differential diagnosis of pathogenic bacteria, fungi, syphilis, the PCR methods have become widespread, and I'm glad to say less expensive. The PCR Expert Ultra is available in many countries and can be very, very helpful in diagnosis. The reason we teach my residents to recognize TB with exudative contrast enhancement and hydrocephalus is because normal antibiotics treating pyogenic meningitis will fail in a patient with TB. And we should start treatment early, and it usually lasts for 6 months. And the patient very often will require steroids to stop the inflammatory complications that can give rise to all of the downstream bad effects of TB meningitis. So this is a very important diagnosis to make. Very often, we will make that in patients in vulnerable populations, such as migrant workers or immunocompromised HIV patients. And here's an example of hydrocephalus, and here's an example of tuberculoma in a patient with tuberculosis. Remember what I said about the complications? This is an MRA of a patient with TB meningitis. And you will recognize that the internal carotid artery is within normal limits. The anterior cerebral artery is well seen, but the middle cerebral arteries bilaterally have disappeared. So there's no time of flight flow into them because there's severe vasculitis, and this patient went on to have infarcts because the perforators are closed and occluded, giving rise...
Sir, there's no image shown on the screen.
I'm sorry?
There's no image shown on the screen for what you're describing. MRA.
Oh. Let me try that again. Can you see the screen now?
Yes, sir.
Oh, okay, good. So here's the MRA. So I will go over very quickly. Normal ICA, normal ACA, absent NCA bilaterally, giving rise to infarcts in the basal ganglia. This is obtained 1 week after. So these infarcted areas have decreased in signal intensity. There's corona radiata infarction because the perforators in the MCA that supply the basal ganglia are cut off. In addition, you can also see meningitis in the sulci and another infarct in the white matter of the brain. The visualization of the vasculitis in the MCA will benefit when we use black blood, black CSF MR imaging. And here's an example before contrast enhancement. You can see that the MCA branches still look quite patent. And after contrast enhancement, you can see the abnormal contrast enhancement outside the MCA and decrease in the caliber and vasculitic infarctions visualized very well on black blood, black CSF vessel wall imaging. Okay, so that brings us to question B. This is the patient with the involuntary movement and jaw grinding. Remember, we discussed what it might be, and here you can see very florid enhancement. And it looks very suspicious for meningitis, but many of you have said it's none of the above. But you're right. But what is it if it's not a meningitis process? So here we have a patient with abnormal prominence of the sulcal areas, and it's unilateral, and it also affects some of the deep venous structures as well. Here is the other slice, and we were very concerned for tuberculosis, but the patient did not have a fever. The patient was relatively well. In fact, she was an outpatient, and we recalled her, and we did this. This is a time-of-flight MRA, and this is the digital subtraction angiogram. So it turns out that the patient had internal carotid artery flow, MCA, ACA flow on the normal side, very poor flow of a rat tail, thin flow in the ICA, very poor flow in the MCA, and look how the collaterals are trying to supply from the posterior cerebral artery in the meningeal areas. This patient had a chronic dissection of the ICA, giving rise to pale collaterals. And this is commonly known as the IV sign of abnormal contrast enhancement in the leptomeningeal spaces. So don't forget, ischemic collateral vessels can mimic meningitis in some instances. So this is a very rare condition. We published it as a case report way back in 2005. So be aware that not everything that has enhancement in that pattern is caused by meningitis. And I'll bring you back to the differential diagnosis for leptomeningeal contrast enhancement. One of them is ischemia, the IV sign. So to recap, the leptomeninges can be abnormal in pyogenic meningitis with contrast enhancement, tuberculous meningitis, typically basal, typically exudated. It can be caused by the IV sign. And lastly, leptomeningeal contrast enhancement can be caused by meningeal carcinomatosis from metastatic disease. This patient, I think, had a lung cancer from the literature in AJNR. Okay, so I will come back to where I started off before we riffed onto TB and toxoplasmosis. We were talking about HIV infection. So don't forget, there are other classic appearance of Cryptococcus and Aspergillus, etc. And we now discuss a little bit more about the white matter abnormalities and iris. So we had a patient who had a basal ganglion enhancing lesion that was initially treated with toxoplasma medication. Unfortunately, it did not get better. The lesions remained the same. They didn't get smaller or disappear. So we were very suspicious if this could be differential diagnosis of lymphoma. And when we performed spectroscopy, we saw elevated choline that gave us a suggestion that this was caused by primary CNS lymphoma. This patient was ultimately uh, diagnosed as CNS lymphoma. This is an example of a patient with HAND. In HIV-associated dementia or cognitive impairment, the virus itself attacks the brain. So the brain has HIV virus, but no opportunistic infection. It destroys the white matter in a very bilateral, symmetrical fashion. Here you can see that the inferior portion is bilateral, symmetrical, diffuse, generalized, high signal intensity, and also in the upper portions. 4 months later, with highly active retroviral treatment, there is slight improvement. In contrast, this is a patient with PML. PML also gives you white matter, high signal intensity, and this is a demyelinating process rather than destruction by the HIV virus. The demyelination is caused by the JC virus, not the HIV virus, and it's typically focal and doesn't occupy space, and typically doesn't have contrast enhancement after injection. So PML and HAND typically affect the white matter, and unlike an opportunistic infection, PML doesn't get contrast enhanced and doesn't occupy space. Iris is a process by which ART treatment becomes effective and immune system recovers. So when the immune system is reconstituted, the contrast enhancement becomes very, very active after successful treatment with antiretroviral medicine. So paradoxically, before there was no immune system response, no contrast enhancement, no edema. Paradoxically, after the patient has antiretroviral, it becomes worse on MRI. So this dysregulated immune reaction unmasks the subclinical infection by the strong host response, giving rise to features like we see in meningitis, particularly TB. The trick to recognizing iris and saying that the patient should stay the course, continue taking the medicine and the antibiotics, the clue is in the CD4 improvement and the decreasing viral load. So this gives us strong support for iris as a diagnosis. The course of iris is usually self-limiting and the patient gets better. A small minority will have fulminating um, fulminating inflammation and may even die. So TB is the classic that will give you iris. Therefore, the recommendation is to start anti-TB treatment in a patient who has pulmonary TB and then start ART later to prevent this, because you need to rule out in a situation that looks like iris whether there is an opportunistic superinfection or drug toxicity. So I hope I've made myself clear, because this is sometimes very confusing and very difficult to make a diagnosis of iris. Okay, let's take a break and do a mental shift. It's about 1 hour in, so I shall go a little bit quicker and move on to the next phase, where we will talk about viruses, and I'll cover very, very briefly the inflammatory conditions, and then we'll take questions, because I'm sure everybody will be quite tired by then. Okay, let's press on. Let's talk about encephalitis. Amongst the viral infections, herpes simplex type 1 has a classic example pattern that we should pay attention. Other viral encephalitis patterns of involvement will also be explored. And here's the classic HSV type 1. In this condition, the abnormality typically shows high signal intensity on T2 weighted MR images and flare. You can see straight away that the flare is much better at delineating the high signal that affects the hippocampus and the temporal lobes, the insular cortex, and sometimes the inferior frontal cortex and the cingulate gyrus. On the T2 weighted MR image, sometimes you can make out swelling and high signal intensity, but the CSF high signal intensity is very glaring, and sometimes we can't see the high signal, especially if the lesion is small. So flare suppresses normal CSF and allows us to see the high signal intensity a little bit clearer. But the unfortunate disadvantage is sometimes it isn't easy to tell whether something that is high signal, when it's not swollen, is actually abnormal. So sometimes there's false positive on flare, but it is more sensitive, certainly, than T2 weighted. In some patients with herpes simplex, high signal intensity can be seen on DWI as well, but it's not constant, and it gives, if it's present, it gives us stronger suspicion, and we should be able to distinguish it from ischemic infarction quite clearly. So flare is still a very strong mainstay. Herpes simplex encephalitis typically affects the hippocampus and temporal lobe, particularly insula as well, but very often it spares the basal ganglia, and there is a very sharp distinguishing border between the insula and the normal basal ganglia. HSV is typically not affected. So that comes to question A. In a classic patient with fever, headache, seizure, leukocytosis, it's not Wilson disease, because Wilson's affects the thalamus, sometimes the basal ganglia. It's not malaria, because the classic malaria lesions are small, white matter lesions. And it's not metastasis, because that's usually a ring-enhancing focal mass. This is cortical involvement from herpes encephalitis. So amongst the viruses, the classic pattern is a herpes virus, HSV1 and 2. Other viruses that belong to the herpes group include varicella zoster, chickenpox and zoster, CMV, EBV, and human herpes virus 6. These are very difficult to diagnose, but we're getting better with PCR. Zoster, I will share a little bit because it typically doesn't have a classic MR appearance, but herpes zoster is one of the most important causes in Singapore of childhood ischemic infarction, because just like TB, the zoster virus can attack the MCA, cause vasculitis, ischemic infarction, and thrombosis. There is another group of viruses called arboviruses. They're arthropod-borne, either mosquitoes or ticks. And the classic is Japanese encephalitis, West Nile, and dengue. There are other tick-borne viruses in Europe and Far East. This group of patients typically shows abnormalities in the thalamus. I want to say a few words about viruses that can affect the brain. I've listed 3 groups of neurotropic viruses. In other words, these viruses focus and home in on the CNS. Rabies, herpes, and arboviruses will attack the brain and will colonize the brain. And if we have a virus culture of the brain, we will find the viruses because they are neurotropic and they're in the CSF, they're in the brain material. However, the other viruses are very seldom isolated from the CNS. And many of the brain abnormalities associated with influenza, COVID, and SARS are due to other complications rather than neurotropic invasion of the central nervous system. We can discuss that a little bit later if anybody's interested, but here I would draw your attention to the herpes pattern and the Japanese encephalitis pattern, which is this. The typical appearance of Japanese encephalitis is that there's bilateral, almost symmetrical thalamus involvement, well detected on FLAIR or T2-weighted MR image. Sometimes they will affect the basal ganglion, sometimes they will affect the brainstem and others, but more consistently it will affect the thalamus. And they may hemorrhage. Here is a patient with DWI and ADC. Unlike pus in abscess or meningitis or even encephalitis, restriction isn't always restricted and DW isn't always high in signal intensity. We have to make a differential diagnosis with bilateral thalamus abnormalities because one of the differential diagnoses is a post-infectious acute necrotizing encephalopathy, which is immune-mediated and is typically described as ANE. And ANE can be seen in Japanese encephalitis as well as influenza, among other viruses. So I'm going to make a short summary. We've gone through the approach and the techniques, emphasizing the usefulness of diffusion and SWI. We've got pattern recognition of meningitis, of contrast enhancement, as well as pus in the subarachnoid space and ventricles, well demonstrated by DWI. We described ring-enhancing lesions, particularly in low ADC and high DWI signal in patients with untreated pyogenic abscess. This is an oversimplification because the patterns will overlap and specific pathogenic diagnosis is often not possible. We need confirmation with CSF or biopsy for the pathogen and its sensitivity. We went into HIV, talked about toxoplasmosis and tuberculosis, as well as iris. Then we just stopped off with viral encephalitis, particularly the hippocampus pattern and also the Japanese encephalitis bilateral thalamus. So this is a short summary. Now I'm going to go very quickly and pick up the pace on very rare conditions that are inflammatory diseases. So if you can't keep up, don't worry, read the PDF if you're interested. If not, this is still a works in progress. There are many changes in the terminology in the literature, and many radiologists are not aware of this. Not such a big deal because it's unusual. Amongst the inflammatory diseases of the CNS, the LGI1 antibody encephalitis, neurosarcoid, IgG4, primary CNS vasculitis, and granulomatous disease with polyangiitis, GPA, are the important ones we need to have at least a passing recognition. So let's come back to the word encephalitis. Encephalitis describes a clinical syndrome that affects the brain. So if you have meningism, if you have fever, neck stiffness, but fully conscious, fully alert, no cognitive abnormalities, no seizures, that's just meningitis. If there is encephalitis, there's usually cognitive, motor features. That clinical syndrome is very often caused by an infection, but it can also be immune mediated. In reviews that were performed, the patients that present to hospital with encephalitis, a large majority of them in the past were unknown. Now we can detect the virus PCR more readily, and more viruses are being identified. So the majority of unknown cases is falling. At the same time, PCR is also helpful in making immune diagnosis, and more inflammatory diseases are getting identified. So that's good news for patients. The bad news is we have to keep up with the literature and learn more and more. So in inflammatory diseases, this class of CNS pathology, typically we encounter them in three clinical situations. Number one, a patient with a known rheumatological disease such as systemic lupus erythematosus or Sjogren's syndrome. A patient with SLE and clinical syndrome of brain abnormality typically has MRI abnormalities. Secondly, if we have a post-infectious immune-mediated inflammation, the patient may also present with encephalitis. And here we're looking for patterns of ADEM and ANE, which I've just described. And finally, paraneoplastic syndromes in a patient with known cancer or sometimes unknown cancer can give you a clinical syndrome of encephalitis. So those are the clinical situations that we typically see them. And here, let's talk about the imaging patterns in this class of diseases. One of the most common features is that they are normal. The second common feature is that there can be leptomeningitis contrast enhancement, much more than pachymeningitis. The third pattern is they can have encephalitis, abnormal signals in the brain parenchyma, and finally, vasculitic diseases, particularly primary CNS vasculitis, causing infarction and all kinds of confusing patterns. So it's very complex. The radiologist aims to facilitate early treatment that will diminish the morbidity and disability, try to avoid invasive brain biopsy, and if the MDT decides that it's inevitable, to direct the most likely positive biopsy results, the most abnormal area, to get a definitive diagnosis. We can also trigger appropriate tests, particularly if we recognize a paraneoplastic syndrome, to trigger a CT scan screen for cancer in the remote areas. Or if we make a diagnosis of, say, neurosarcoidosis, we can trigger a CT chest to look for sarcoidosis in the chest. So in this journal called Continuum in 2023, there is a very helpful description of the different types of abnormalities that we can expect to see. I mentioned leptomeningeal abnormalities. I also mentioned limbic areas, and don't forget, many other areas can be abnormal. So let's go to the LGI1 diagnosis. Herpes simplex we've covered, looks like it affects the hippocampus, insula, spares the basal ganglion. LGI1 antibody is very similar to herpes. It affects the hippocampus bilateral. The terminology is changing. Previously, it was called autoimmune etiology. And this is a 2013 study trying to see what is the difference between herpes and autoimmune encephalitis. There are very few differences, except that the psychiatric symptoms and the presence of tumor is highly associated with autoimmune encephalitis, whereas fever, and remember what I said about absence of basal ganglia involvement, is typical for herpes simplex infection. So the terminology is changing. Just 4 years ago, we published that this disease was called VGKC. Now, VGKC has been identified as LGI1 and a different Casper marker. So the LGI1 is the pattern that we associate with this bilateral hippocampal high signal intensity on flare. So, in addition, I mentioned the other immune mediated. This is acute disseminated encephalomyelopathy, post-infectious, multifocal, high signal intensity on T2 and flare involving the white matter. Acute necrotizing encephalopathy, particularly in childhood and post-infection, typically affects the basal ganglia around the thalamus bilaterally, and they can also show abnormal signals on DWI. There may be other involvement of areas, and they finally may have hemorrhagic leakage of blood products as seen here on T1 weighted high signal intensity from methemoglobin. These are other examples of ANE with high signal intensity and susceptibility on GRE. I mentioned sarcoidosis because sarcoidosis is a multi-system inflammatory granulomatous disease that mimics tuberculosis, and it's granulomatous but not acid-fast bacilli. So TB features are very important when it comes to making the differential diagnosis. We have to think about neurosarcoid. And in the brain, the abnormality can mimic an encephalitis, and it can also show leptomeningeal inflammation, very similar to tuberculosis. The pituitary, the hypothalamus, the optic nerve, and other large nerves can be involved. And finally, inflammation in the spine. IgG4-related disease is also an inflammatory condition, but this time it's fibro-inflammatory. Therefore, it affects the pachymeninges and the pituitary, also the salivary and lacrimal glands. And here a feature that is helpful is that the signal intensity on T2 is low compared to other inflammatory or infectious diseases where T2 signal is high. Previously called vaginous granulomatosis, GPA sometimes presents as a sinus mass, and sometimes presents as leptomeningeal contrast enhancement. And finally, among inflammatory conditions, don't forget CNS vasculitis can cause infarcts as well as other features on imaging. So the syndromic MRI approach to inflammatory diseases, lepto, pachy, cortical. As you can see, these are also features that can be found in infection. So that's why infection and inflammation are typically studied together. So all this, especially the inflammatory conditions, is very, very confusing. How can a radiologist help? Well, we need to understand the mimics and pitfalls. We need to know that inflammatory conditions exist. We can try advanced imaging techniques, and we perform well in multidisciplinary team meetings. We need to be aware of the MRI patterns and the differential diagnosis, such as the mimic of schistosomiasis for brain tumor. We can use DWI and SWI at the MDT conferences. So in summary, I will go through this again. We use techniques. We use our understanding of pattern recognition. We can detect meningitis and small amounts of pus. Use the ring-enhancing low ADC, and be aware of the overlapping patterns, particularly in hippocampus high signal intensity, that distinguishes herpes and LGI1 antibody immune-mediated encephalitis. So we help by discussing with our clinical colleagues, and be aware that this is oversimplified. I've talked about 3 patterns. I've talked about some pathogenesis that we can see, such as DWI and SWI, and the importance that we play. So I think you're all very tired of hearing from my voice. Let's see what we have in the chat, and we can take questions for the remainder of the time here.